I'm assuming you can all see my slides, yes? Can somebody confirm that?
Yes, we can, Art.
All right, terrific. So we'll spend some time on this slide for what the definition of high-risk prostate cancer is, because there's not perfect agreement amongst everybody about what it is, although you'll see some themes here. And let me just say at the beginning that only about 10% of newly diagnosed patients present with what we call high or very high-risk prostate cancer. So it is the minority of people. And the reason for that is that PSA is pretty sensitive for detecting early-stage prostate cancer. Let me also say, although I'll have more detail about this, if you start out on active surveillance, if you fit the relatively narrow criteria we use for surveillance of low-grade cancer or favorable intermediate risk cancer, a little bit of 3+4 disease without any other adverse features, it's incredibly rare for that person to progress to high-risk cancer. Incredibly rare for that person to progress to high-risk prostate cancer over the first few years. I guess if left untreated for 10 or 15 years, I've seen that happen. But in the short term, if you're monitored on active surveillance, you won't be in this situation. And we use other triggers, which we'll talk about a little bit, to identify people who are at risk of getting to this stage and treat them before then. So there are a number of different classification systems for high-risk cancer, and we'll start here with the NCCN high-risk prostate cancer. NCCN is the National Comprehensive Cancer Center Network, and that is those are National Cancer Center Institute-funded centers, cancer centers, and each of those sends a representative to this council that once a year looks at every different kind of cancer, including prostate cancer, and based on published data and expert opinion, come out with guidelines. So we're in the era now where we're transitioning from the old tools that we have, which is basically how much cancer is on the biopsy and how aggressive does it look under the microscope as established by the Gleason's grade, to a molecular and an imaging era where we have so much more information that we can glean about the nature of the cancer that we're in what we call the precision medicine era. And I'll talk about that. So the definitions that we're going to use here are based on the older criteria of the amount of cancer and the grade of the cancer. So for NCCN high-risk prostate cancer, any PSA above 20, or any Gleason's grade greater than 8, or a clinical stage of T3A, which means that the cancer extends outside the rind around the prostate, if you think of it like a citrus fruit. So that's high-risk prostate cancer based on NCCN criteria. And then even more aggressive than that is NCCN very high-risk prostate cancer. So that's primary Gleason's pattern 5, so that would be a total Gleason's pattern score of 9 or 10, which accounts for probably just 1 or 2% of newly diagnosed cases. Or a more advanced clinical stage, and what you see here illustrated is if the cancer extends into the 2 glands next to the prostate, the seminal vesicles, or very high volume Gleason's score 8 to 10. So you get the sense here that the more high-grade cancer you have, that puts you in a higher risk category. So the D'Amico high-risk prostate cancer is named after a radiation oncologist at Harvard named Anthony D'Amico, who's made many contributions. And that's pretty similar to the NCCN high-risk and very high-risk cancers. And then there's the European Association of Urology, which is an organization that's very similar to the NCCN that has similar criteria, PSA above 20. They include Gleason's grade greater than 7, so that would be 8 or above. I guess there's no equal sign there, or locally advanced disease. So you get the idea here. It's about tumor volume, it's about PSA, and it's about grade of the cancer, and that's really what defines high-risk cancer, all of those things. So let's talk about the tools that we have that allow us to stage the cancer and understand what the biology is. One that's tried and true, and it's been around since the early part of my career, is PSA, prostate-specific antigen. And in men, the average man who walks into the office with a worrisome PSA, someone over 50 whose primary care physician says your PSA is 5 or 6, go see a urologist. Most of those patients don't have prostate cancer. most elevations in PSA actually come from non-cancerous prostate enlargement, BPH, or benign prostatic hypertrophy. And we have new ways of sort of sorting through that, and I'll tell you about that in a minute, although I didn't think to put a slide in. If you have cancer, though, higher PSA levels usually mean more aggressive disease. So what do we mean by higher PSA levels? Once you start getting PSA levels greater than 10 to 15, then that usually means you've got a large volume cancer or a higher grade cancer, grade 7 or 8, something like that. There are two exceptions. One is that some very high-grade cancers don't make much PSA. They're so what we call dedifferentiated, that their cellular metabolism isn't normal and they don't make much PSA. And then as we move into the molecular era, about 10% of early-stage prostate cancer is driven by a gene called SPOP. And it turns out that SPOP-associated tumors make more PSA than the other kind of tumors that are molecularly defined by something called ERG fusion. And so you can have a higher PSA, but still have organ-confined cancer that's curable if it's an SPOP-associated tumor. And we're just entering the era now where testing biopsy specimens for these specific molecular defects or changes is going to allow us to better characterize things. Let me get back to a minute, to a new tool for someone who is referred to a urologist with a PSA of 5 or 6 or 7 or 8 or 10 or something like that. PSA by itself, as I've mentioned, doesn't distinguish cancer from non-cancerous prostate growth very well. So there are two tests on the market already, one called the 4K score and the other called the Prostate Health Index, that can help determine if an elevation in PSA is due to cancer. And there are some other urine-based tests. There's the MySeq score from the University of Michigan, and there are one or two others. But there's a new one that we've developed in Cleveland that I actually think is the best. All the other markers allow us to avoid biopsying patients with an elevated PSA about a third of the time, 30 to 35% of the time, because they're at low suspicion of high-grade cancer. ISO-PSA is this new test that we've developed that is being rolled out commercially now. And it can allow us to avoid prostate biopsy in more than half of patients who have an elevated PSA. And it's a simple blood test that measures PSA and dozens of other related proteins and works a lot better. And so we're able now, when we see a patient in the office with an elevated PSA, unless they have a rock-hard prostate that we're certain is prostate cancer, we usually do an ISO-PSA test. That's what we call a reflex before proceeding to biopsy. If their ISO-PSA level puts them at low risk of high-grade cancer, then we do not do a biopsy. But that's PSA. For newly diagnosed patients who are considering active surveillance, let's say you were referred for a PSA of 5 or 6, and one of these reflex tests indicated that you needed a biopsy, and you have a biopsy that shows low-grade cancer, how do you know if you're a good candidate for active surveillance? The first question that I ask myself when I see a newly diagnosed patient with prostate cancer is not what treatment is best for them, but it's, is treatment necessary? And that's very different than the start of my career 30 years ago, when we really believed that every cancer that was detected needed treatment. And in fact, we treated every cancer that we detected. And we overtreated a lot of men who had low-grade cancers. So the challenge is that using standard biopsy techniques, and the old technique that we've used until very recently is transrectal ultrasound-guided biopsy, we know that we often undersampled the prostate, meaning that we knew that there was some other cancer hiding in the prostate, but we didn't have the technology available to help us assess it completely. And there are two kinds of undersampling. One is biopsy undersampling. Did the needle hit the highest grade tumor? And the second kind of undersampling is a newer one that we understand now. Is what's the true biologic potential of the tumor that's in the prostate? So it turns out that about 15% of low-grade cancers, Gleason's grade 6 cancers or Gleason's grade group 1 cancers that look benign or not very, I don't mean benign, but not aggressive under the microscope. It turns out that about 15% of them actually have molecular changes, molecular features that put them at risk for developing into something that needs to be treated. That's what we call biologic potential. And we just now have tools to understand and identify which tumors those are. So for biopsy undersampling, we have a tool called magnetic resonance scanning of the prostate, which has really revolutionized the way we do biopsies. And what you see here on the bottom here is a graphical illustration of an MR appearance of a prostate in red here. And this little wiggly green box here is a target, an area on the MRI that an expert radiologist said looks suspicious for cancer. And using what's called fusion technology, where we do the transrectal ultrasound and we fuse the image that we get with the MRI with the target marked, we pull up some crosshairs. That's what this target is here. And we can precisely pass our needle, which is what this cylinder is here, right into the target. And that has really revolutionized the way biopsies have been done. So transrectal fusion biopsy has been the standard until very recently. As a field, we're in a paradigm shift now of doing these biopsies transperineally, meaning instead of, we still put the ultrasound probe in the rectum, but instead of passing the needle through the rectum, we pass the needle through the skin between the rectum and the testicles. That is more accurate, and it also virtually eliminates the risk of getting a bacterial infection, a bacterial bloodstream infection that can hospitalize patients and make them sick. That's how we get by biopsy undersampling. One of the challenges with MRI is that it does not see all high-grade cancers. It misses about 20% of high-grade cancers. So if you have a very high clinical suspicion of prostate cancer and a negative MRI, you still need a biopsy. We do random biopsies under that circumstance. But let's talk about biological undersampling, and this is what's relatively new, are the use of what are called genomic tests. And there are 4 on the market that you see here that actually allow us to understand something about the biology of the cancer that's not visible even to the most trained pathologists when they look at a biopsy under a microscope using white light. These tests reveal 2 things. One, whether the low-grade cancer that was biopsied actually has molecular features that have given it already the biologic potential to become more aggressive. And 2 is they actually can tell us something about the biology of the whole prostate. For most prostates, not all, but for most, if you have more than one tumor in the prostate and you only sample one and you do one of these genomic tests, which means sending a piece of the biopsy tissue off to a company to look at the molecular features of the tumor, you can often tell whether or not your biopsy missed higher grade cancers. So that's really helped us identify which patients are really safest for active surveillance. So what these tests predict for, something we call adverse pathology, which are features that are about halfway between the lowest grade cancers that we know don't need treatment and can stay on surveillance, and features of the highest grade cancers that qualify for what I called before high risk and very high risk cancer. So this puts us in the intermediate ground, which is where we want to know. In the absence of these features, surveillance is safe. In the presence of these features, one of 2 things should happen. Either you should get treated or you should be followed incredibly closely to avoid running into the rare circumstance where you develop high-risk cancer. So what's adverse pathology that these molecular tests, these genomic tests predict for? It's high-grade cancer, which is grade 4+3. So that's the bad kind of grade 7 cancer. And if it's more than 50% pattern 4, it becomes Gleason's grade group 3. And then disease outside the prostate, which also we know is a sign of aggressiveness. So if you have cancer, as I showed on the first slide, that goes through the rind around the prostate, that's called extraprostatic extension, and that's an indicator of aggressiveness. Invasion of the seminal vesicles, which finds high-risk cancer in some of those systems. Cancer in a lymph node, and then something that the pathologist can see under the microscope, but almost no non-expert pathologists pay attention to. It's called cribriform glands. And it's a specific way that the cancer glands look under the microscope. And it takes a very trained pathologist to recognize this. And our pathologist, our primary prostate pathologist clinic, is a man named Jesse McKinney, is in the process of redefining the grading system for prostate cancer that's largely, although not exclusively, based on this cribriform pattern here, and is going to simplify things. Eventually, in a few years, I think we're going to get to the point where we just have a dichotomous two-tier system of prostate cancer grading. Either you have favorable histology or you have unfavorable histology. If you have favorable histology, you go on surveillance. If it's unfavorable, you need treatment. So these genomic tests can increase our ability over MRI and biopsy alone in correctly predicting the presence of these features, which generally should exclude patients from active surveillance. And that would be true if that's at your initial diagnosis. And it can also be true and useful if you've been on surveillance for a while and you have a repeat biopsy a few years into that, and maybe the biopsy's gone from Gleason's 3+3 to Gleason's 3+4 with 10% pattern 4. And you can't really know whether that means that it's real progression to the point that it needs treatment, or maybe that pattern 4 has been there and was just missed on prior biopsy. These genomic tests, these gene expression tests, can answer that question for us. And we just published a couple of months ago this new data using one of these genomic tests called Oncotype. Oncotype was the first of these tests that was widely used and on the market. And it's reported as a GPS score that goes from 0 to 100, actually, although on the axis here it only goes to 60. The higher your GPS score, the more likely you are to have these features of adverse pathology. And in my opinion, those are patients who need treatment. And this data really shows us that. So here we see the likelihood, just look at this dark blue line here, the likelihood that 20 years after diagnosis that you would get metastatic cancer or die from prostate cancer based on the GPS score. And what you can see is that if your GPS score is below about 25 or so, your risk of getting metastasis and your risk of dying of prostate cancer is very, very low, certainly under about 4%, maybe even 3% for metastatic disease, and your risk of dying is virtually zero. On the other hand, if your score is above 25, 29, 30, something like that, the risk of getting metastasis or dying of prostate cancer goes up. And the higher the score, the more likely those things, or the more at risk you are, I should say, to have that happen. So this really suggests, unlike MRI, which cannot predict what might happen to you 20 years hence, suggests that if you have a low GPS score or a low score on one of the other tests, that starting out on surveillance, it's safe. It doesn't guarantee that you're not going to get to the point where you need treatment, but it's certainly safe. Just having a low score at the beginning means your likelihood of being alive and free of disease 20 years hence is really excellent. And it also says, maybe even more strikingly to me, that if you have a high score, that's a risky tumor. That's a high-risk tumor as defined by molecular features in a new way that's different from all the other high-risk features that I mentioned on the first slide. And this really identifies those cancers that need treatment. And there's some unpublished data now, spearheaded by a radiation oncologist named Dan Spratt, who was at the University of Michigan and is now at University Hospitals here in Cleveland, using another of these molecular tests called Decipher, which pretty much measures the same thing as Oncotype. What they measure is the biologic potential of the tumor. And this was from an observational study in Michigan from, I don't know, maybe 100 urologists, 13 different urology practices. And what it showed is that if you started out on surveillance and you had a low Decipher score, that you stayed on surveillance a lot longer than someone who started out with a high Decipher score. What does that mean? You go on surveillance, you have to be rebiopsied in a year. If you started out with a low molecular score, then at a year, it's unlikely that you progress to one of the triggers that I mentioned that would indicate you need treatment. On the other hand, if you have a high Decipher score, look how rapidly people fall off surveillance. About 50% of them fall off within a few months, that again suggests that you may not be a good candidate for treatment. And here's the real telling data here. In patients who are on surveillance, who had Decipher scores as they started surveillance, who ended up needing treatment or deciding on treatment, if you had a low score, this flat line here indicates that you were virtually 100% likely to be cured, even if you started on surveillance a few years ago, and all of a sudden you decide to be treated because your PSA went up, or you have more cancer on biopsy, or it went from grade 6 to grade 7. On the other hand, if you start with a high Decipher score, even if you're treated at the appropriate trigger, your chance of being cured is less. And way out here, I'm sorry, I can't read the y-axis here, excuse me, x-axis. I think it says 30 months, I think, so about 3 years out. At 3 years out, only about 70% of the people who started on surveillance, who had high Decipher scores, who were then treated, were actually cured of their cancer. So this is pretty strong data, in addition to the data I showed on the prior slide, that suggests if you have a genomic test here, when you start on surveillance or when you're into it for a year or two, you get really, really good information out of that test that suggests maybe it's safe for you to continue on surveillance or maybe it's not. So I'm really excited about this because these are new tools that allow us to look into the biology of prostate cancer and help us make better decisions than only based on MRI and what the pathologist sees under the microscope. So I love this cartoon. Cartoon is a woman going to her pharmacist, and instead of handing him a prescription for a medication, it says, here's my sequence. And what I love about this cartoon is you can see the date on it. It appeared in the New Yorker 21 years ago. 21 years ago, it was science fiction. In 2021, this is not science fiction. And some of you may have sent your saliva off to 23andMe or one of those companies, have it sequenced and to learn what it tells about your ancestry and your health and so forth. We are in the precision medicine era in prostate cancer in ways that we never thought of before. And one of them is using these genomic tests for active surveillance that I think is well established now. There's another side to this, though, that is useful in some men who have high-risk prostate cancer. We're not talking about active surveillance anymore. We're talking about patients who have tumors that need treatment. And that's called germline genetic testing. What I showed you before is somatic tumor testing, where you take a piece of the tumor and you get a sequence. Germline genetic testing is the DNA that you were born with. It's what you can blame your parents for. So if you have brown eyes and you want to have blue eyes, that's your parents' fault. It's your parents' genes that determined you have brown eyes. And so there's some guidelines on this now where we are suggesting that people who present with these features, which I'll talk about in a minute, send a blood or saliva sample off to a company or a lab, have germline genetic testing done to determine if they were born with a gene that predisposes them to prostate cancer, because that can be informative for their sons or their brothers or their uncles or their nephews. It can be useful, and in fact, if you're a BRCA carrier, which also increases the risk of prostate cancer, it could be beneficial information for defining cancer risk in the women in your family as well. So generally speaking now, if someone presents with high-grade cancer, Gleason's grade 4+3, we recommend germline genetic testing. If you meet one of those definitions for locally advanced cancers at stage C or T3A or B cancer, we generally do it. And there's a move now amongst medical oncologists to test everyone with metastatic disease who presents with metastatic disease, either at diagnosis or progresses to metastatic disease. And again, the reason is that the knowledge gained from doing this sequencing of the DNA you were born with, and it informs a risk assessment for your relatives. But more importantly, perhaps in today's era, there are certain defects in certain genes, BRCA and DNA repair genes they're called, that determine whether or not, in the right circumstance, if you would be eligible or benefit from using a new class of drugs called PARP inhibitors. If you're on active surveillance, it's really unlikely that this would ever be of relevance to you. But if you start out with a high-risk cancer, grade 8 or above, or high volume grade 7, or invasion of the seminal vesicles, this eligibility for PARP inhibitors could be very relevant to you, because there might come a time, if your cancer progresses, and you fail hormone therapy, that you would benefit from a hormone. So that's two kinds of genetic testing, two different ways to think about the precision medicine era, where next generation sequencing has really helped us manage prostate cancer. And just in the remaining few minutes before we consider answering questions, there are a couple of other imaging tools that are useful. One is prostate MRI. I've talked about this already. This is a pretty standard radiologic technique where you lie on the scanner. Some of you might have started on surveillance a few years ago where they put a coil in the rectum to get a better view now. With 3T scanners, 3 Tesla scanners, that's no longer necessary. And in about 15 or 20 minutes, you can get this high-quality image of the prostate. And this is a man who, on the left here, has no evidence of cancer. The darker area on the top of the prostate is the part that sits around the urethra. That's BPH, non-cancerous prostate enlargement. And this whiter area here, which looks to me like a bird in flight in cross-section, with its wings extended. That's the way I think about it. That's called the peripheral zone, where most but not all cancers come from. This looks perfectly homogeneous and white and benign. But we compare that to this patient over here, who has the same kind of BPH, who has a smaller peripheral zone that also looks bright and white here, except for right here, you see this dark spot. And that's what prostate cancer looks like on an MRI. So an MRI helps us do two things. In someone who hasn't been biopsied, it helps us point our needle in the right direction using that fusion technology that I showed earlier. In someone who's on active surveillance, this can allow us to follow a tumor that we can see. So let's say we biopsied this tumor and it came back Gleason's grade 6, so the lowest grade possible, and it had a favorable genomic score. That's a good candidate for surveillance. But let's say a year or two later, the tumor is a little bigger, and we re-biopsy it, and it's still Gleason 6, or maybe it's got 5% pattern 4, and we don't really know if it has progressed or not. That's where we can do another genomic test. Well, first of all, we can use MRI to re-biopsy the exact same area, and then we can use a genomic test to see if it really has developed molecular features that are necessary for treatment. The other information that this scan gives us is anatomic information that helps us plan surgery. So just outside here, think of this like a citrus fruit cut in half, like an orange with a rind around it. That's this dark area right here. Just outside that is the neurovascular bundle, the nerves that allow for erections. During surgery, we can dissect right in between the rind here and the bundle and save the bundle. Whereas if there's a cancer adjacent to the bundle, sometimes we remove the bundle to be sure that we get all the way around the cancer. And this information on MRI is very useful. So that's MRI. If you're on surveillance, you absolutely should have an MRI. And MRI makes biopsy better. So before I biopsy anybody, again, unless they have a rock-hard prostate that I'm really suspicious has cancer, MRI is the new standard of care. And serial MRIs once a year, once every other year, maybe once every third year while you're on surveillance is important. All right. So there's a big debate raging now about whether MRI or genomics are the better test for monitoring patients on active surveillance or qualifying them for surveillance. And so on this slide, I'm just going to show you how I think about this. These are not really competing tests. They're complementary and they give us different information. So the added clinical value of MRI is not about establishing how aggressive the cancer is, but it's about finding the cancer that we want to know about. So it makes biopsy better. On the other hand, genomics reveals the biologic potential of the tumor in ways that I've shown you already are useful to us. MRI is highly operator dependent, meaning you must have an expert radiologist to look at an MRI and find subtle areas. And I can tell you from experience that even at a high-end place like the Cleveland Clinic, there's variability in the ability of our radiologists to correctly see what's on an MRI. On the other hand, genomic testing takes a piece of tissue and sends it to a laboratory to measure an objective laboratory output. It does not require human expertise, and therefore it is less likely to be subjective interpretation and more likely to be correct. Ease of use If you've had a transrectal biopsy that wasn't MR guided, then in order to have an MRI guided biopsy, you have to have a second biopsy. That's becoming less and less of an issue as we move toward MR guided biopsy in everybody. On the other hand, a genomic test can be measured on the initial biopsy. You need 1 millimeter of tumor on 5 consecutive slices of a slide, of 5 micron slides, which is a nanomillimeter, and you can get a readout that tells you what might happen 20 years from now. That's incredibly powerful. MRI can't do that, and that's what the last box says here. But unlike MRI, genomics can predict what can happen in 20 years. So this is what MRI does. MRI can show you when you're floating on the water that there's a shark nearby, that there's an obvious spot in the prostate that should be sampled, but genomics allows you to see what's under the surface. And if you have this garbage under the surface, that means you have a tumor that has molecular characteristics of high-grade cancer, and you ought to be treated. So that's how they intersect. All right, 2 more imaging studies, and then we'll stop for questions. One is a standard old-school technology, a bone scan. A bone scan is a very simple test where a nuclear medicine physician injects a minute amount of radioactive material, it's usually radioactive technetium, into a vein. It lets you, it circulates in your system for 2 hours, and then you lie under a Geiger counter, and it looks at your entire skeleton. So on the left here in panel A, you see a man who has no evidence of metastatic cancer. But what we look for are dark spots, but we know there are certain areas that are not cancer that look darker than others. So these are the kidneys here because the technetium is excreted in the kidneys. Spine is full of degenerative disease as we get older, and so it looks a little darker. This is the bladder. These are the joints in the pelvis and the knees and the ankles, and this is a pattern that is normal. Compare it, and you don't have to be an expert here to see the difference, to this man over here who has widely metastatic prostate cancer. So if you look at the long bones of the leg, femur, over here you don't see much uptake in the man who doesn't have cancer, but over here you see many dark spots. And in the ribs here, and in the arm bone, the humerus up here. So this is a man who's got metastatic prostate cancer. Bone scans are only indicated in men with high-risk prostate cancer. They are not indicated in people who are qualified for active surveillance because they have a small amount of low-grade cancer. The men who present with high-risk cancer will use this to determine the presence of metastasis. And then the last thing that we're all really excited about are new kinds of PET scans, positron emission tomography scans. Called PSMA PET. PSMA is a molecule that is expressed by prostate cancer. It was actually cloned by one of our retired scientists at the Cleveland Clinic when he worked at Sloan Kettering back 40 years ago, 35 years ago, when I started my career and actually worked with him in the laboratory. I didn't have anything to do with that project. He did. But it's taken that long to get this to the point where it does 2 things. This is it's like a bone scan where this radioactive material that is a monoclonal antibody that hones to cancer that expresses PSMA gets injected, and then you have a CT scan and this bone scan like PET scan, and you can see where the cancer is. So again, some normal tissue shows up here. So this is liver, the red things are kidneys, and this is bladder. But all these green dots here, 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 and here, these are lymph nodes that are too small to otherwise be seen on any other imaging. If you had a CT scan, you wouldn't see these. But when you do the PET scan and the CT together, you can see where the lymph nodes are. And so this kind of technology has been available at just a few places, at UCLA and University of California, San Francisco. However, the FDA has just approved a new PET scan, PSMA PET scan that's going to be available across the country in the second half of the year. We expect to have it in Cleveland in late July and probably elsewhere in Ohio as well in late July. And this is going to revolutionize how we stage people because this sees things that are invisible to all other kinds of scans. And I'll give you an anecdote. Last year, I operated on a man who had high-risk prostate cancer. He had an MRI that suggested his cancer was contained in his prostate. He had a bone scan that was negative, showed no cancer. We took out his prostate. PSA never went to zero, which means he still had some cancer in him, despite a pretty favorable pathology report on the prostate. So we repeated the MRI of the pelvis and repeated the bone scan, both negative again. And he had a PET scan, and it turned out he had one spot of cancer in a rib that was missed by all the other cancers. And so he got that rib radiated, and his PSA went to zero. And I have another patient very similar to that who had a lymph node in his chest, just like this man has right here up in the chest behind the heart. And same sort of deal, he was radiated and so forth. So PSMA imaging is going to revolutionize how we stage cancer and understand who really has cancer localized to the prostate and can get away with prostatectomy or radiation alone, and who has more metastatic disease. And the last thing I'll close with, what's really exciting, is that there was just a clinical trial reported using PSMA PET scan linked to a radioactive molecule called lutetium-177 that actually can kill cancer. And what that trial showed was that in men who had failed hormone treatment, whose cancer was progressing, if you treat them, not only image them, but you treat them with PSMA PET linked to lutetium, a lot of the cancer regressed and they actually lived longer. And we're all very excited by that, because if you were to use that in someone who had a really minimal amount of metastatic disease like this man does, it's possible that we could cure this patient who has metastatic prostate cancer. And that's remarkable, because in my 30 years of practice, I only know of one patient who had biopsy-proven metastatic prostate cancer who is already 10 years out from treatment and has no evidence of cancer. So that's the exciting thing that's on the horizon. So that is all the slide data that I have, and I would be happy to take your questions on anything that I've covered or on any other topic related to prostate cancer.